Decisions about whether to pursue available testing of the fetus should be made by the recipient, however. Surrogate parenting. A surrogate mother may enter the picture if the woman is infertile or cannot carry a fetus to live birth. The surrogate mother may supply her uterus only, gestational carrier, with the infertile couple supplying the sperm and ovum. Or she may be inseminated with the male's partner sperm and carry the fetus to birth, thus supplying both the genetic component and the gestational component. Surrogacy is different from therapeutic insemination with donor sperm because it is not anonymous. In addition, the woman who carries a child may form bonds with the fetus and male-female during the months of pregnancy. For these reasons, extensive interviews and counseling of both the infertile couple and the surrogate mother are required. Money paid to the surrogate mother can raise ethical issues. Could a poor but fertile woman feel compelled to provide her body for a more well-to-do couple? However, not compensating a woman for the real physical and emotional risks of this undertaking can be construed as coercive as well. It also should be considered that the male-female partners will likely need to provide insurance coverage to the surrogate or gestational carrier. Unfortunately, custody of the resulting child has been the issue in several court cases involving surrogate mothers. In the Baby M case, a woman who was inseminated with the man's sperm refused to relinquish the baby as stated in the contract between the birth mother and the infertile couple. Ultimately, custody was awarded to the man providing the sperm and his spouse, but visitation rights were granted to the surrogate mother. Custody issues when the birth mother is a gestational surrogate are clearer than when she also donates her ovum to the child. Courts have more often recognized the genetic parents as the legal parents and upheld the contracts between them and the gestational surrogate. Assisted reproductive technologies. More than 1% of births in the United States each year are brought about by assisted reproductive technologies, ARTs. The definition used by the Centers for Disease Control and Prevention is specific: surgically removing eggs from a woman's ovaries, combining them with sperm in a laboratory, and returning them to the woman's body or donating them to another woman. ART involves medical, surgical, laboratory, and micromanipulation techniques used with ova and sperm to improve the chance of conception. Simpler evaluations and other treatments often precede or accompany ART therapy. Annual national summary and fertility clinic success rates are available in ART reports and resources at cdc.gov. In vitro fertilization. IVF may be done to bypass blocked or absent fallopian tubes for male factor infertility or for unexplained infertility in either the man or the woman. The physician removes the ova by ultrasound guided transvaginal retrieval, or occasionally laparoscopy, and mixes them with prepared sperm from the woman's partner or a donor. The ova are examined to determine whether fertilization has occurred about 18 hours after addition of the sperm. The fertilized oocytes are then returned to the uterus or may be cultured for 48 to 96 more hours, allowing cell division for a total of 5 days. The number of fertilized ova returned is individualized, but single embryo transfer is slowly lowering the rate of multiple births from the implantation of multiple embryos, without compromising success rates. Older women may have more ova transferred than younger women to improve their chances of pregnancy without greatly increasing the risk for having a triplet or higher pregnancy. IVF is the most common of current ART procedures. IVF is used to do pre-implantation genetic diagnosis for fertile couples having a high risk for a baby with a genetic disorder. Embryo transfer, ET, combined with IVF, IVF-ET, has become more common. Gamete intrafallopian transfer, GIFT, and zygote intrafallopian transfer, ZIFT, are modifications in which sperm and ova are placed in open fallopian tubes. Variations of ZIFT include tubal embryo transfer, TET, also known as tubal embryo stage transfer, test, which places the conceptus in the fallopian tube later than gift. Ultrasound guidance targets the best location to obtain the ova. Intracytoplasmic sperm injection, ICSI, is a technique in which a single spermatozoon, obtained with microsurgical techniques, is injected into the cytoplasm of an ovum. Most ART procedures are done in an outpatient setting. Each procedure begins with ovulation induction to permit retrieval of several ova to improve the likelihood of a successful pregnancy. Sperm are prepared and concentrated in a specialized laboratory as they are for therapeutic insemination. Supplemental progesterone is given to the woman to promote implantation and support the early pregnancy, luteal phase support. Because of the supplemental progesterone, the woman will not have a menstrual period even if she is not pregnant. Transvaginal ultrasounds are used to identify whether one or more gestational sacs have implanted with IVF and to identify if an ectopic tubal pregnancy occurred after methods such as IUI, GIFT, or ZIFT. IVF success rates vary among infertility centers. Not every ovum is successfully fertilized when IVF or its modifications are used. And embryos transferred to the woman's uterus may not always implant. Although twins are the most common multifetal pregnancy, triplets or more may occur, raising issues related to the physical and emotional well-being of the mother and babies. Intrafallopian transfer. The woman must have at least one patent fallopian tube for gift to be an option. The procedure begins in a manner similar to that of IVF, with retrieval of multiple ova and washed sperm. The retrieved ova are drawn into a catheter that also carries prepared sperm. The mix of sperm and ova is injected into each fallopian tube through a laparoscope. Additional prepared sperm may be injected into the uterus through the cervix to improve the chance of successful fertilization. Progesterone is given as it is in IVF. Zygote intrafallopian transfer. ZIFT, often called tubal embryo transfer, TET, is a hybrid of IVF and GIFT. The woman's ova are fertilized outside her body, but the resulting fertilized ova are placed in the fallopian tubes and enter the uterus naturally for implantation. The woman must have at least one patent fallopian tube. Comparison of in vitro fertilization, gamete intrafallopian transfer, and tubal embryo transfer. The primary advantage of GIFT and ZIFT over IVF is that more people and religious groups may find GIFT and ZIFT more natural and therefore more acceptable than IVF. With IVF or ZIFT, evidence of fertilization exists before placement in the uterus or tubes. The GIFT and ZIFT procedures are more invasive, requiring a laparoscopy to place the gametes or fertilized ova in the distal fallopian tube. Tubal pregnancy may result if embryos cannot reach the uterine cavity to implant. For these reasons, IVF is used about 99% of the time if a couple requires ART. Intracytoplasmic sperm injection. Microsurgical techniques combined with IVF may help couples conceive despite severe male factor infertility. Men who have obstructions to their epididymis or absence of an epididymis may be able to father children with the use of percutaneous or microsurgical sperm aspiration. The sperm are retrieved from the epididymis by a percutaneous aspiration of a single spermatozoon with a small gauge needle. Alternatively, a microsurgical incision may be made to aspirate the sperm if the percutaneous approach cannot be used. Sperm obtained are then used to fertilize ova by ICSI. Pre-implantation genetic testing. Couples with concerns about a specific genetic defect in the family may be offered pre-implantation genetic testing of their fertilized ova. As in other types of prenatal screening, pre-implantation genetic testing cannot rule out every potential abnormality in the offspring. Rather, the testing allows parents to make informed decisions about whether to implant the fertilized ova into the uterus. Emotional responses to infertility. Many couples desire natural childbearing. Even if they delay childbearing, many couples expect to have a child before the end of the woman's reproductive years. Those who choose childlessness earlier in life may reevaluate their decision as they age. If a couple does not achieve pregnancy or produce a living child as expected, the man and the woman may experience psychological distress and a threat to their self images. Either or both partners may feel like they have failed themselves or each other. Their marital and family relationships may be stressed, and they may withdraw from relationships they previously found satisfying. Every couple is unique, and many reactions depend on the importance attached to having biologic children. Assumption of fertility. Most couples practice contraception for a number of years before they decide to become pregnant. They may want to first establish a career and financial security, acquire a comfortable home and lifestyle, perhaps travel and live freely without the responsibility of a child. They usually assume they are fertile and may take steps to avoid pregnancy until ready. When they do desire pregnancy, they discontinue contraception and assume that pregnancy will occur within a few months at most. They may plan conception so that the baby will be born at a certain time of year, such as not during the hottest weather, or to avoid major holidays. Either or both partners may experiment with the role of parent as they anticipate pregnancy. They develop a heightened awareness of children and parenting. Being with others who are expecting or already have children is exciting because they plan to join their ranks shortly. They may discuss issues such as full-time parenting by one partner, childcare, and imminent lifestyle changes. They may begin acquiring toys and furnishings that a child will need. Both partners may develop a fantasy child or a concept of what their baby will be like. Growing awareness of a problem. As time goes on without successful conception, the couple gradually becomes concerned about their ability to conceive. If the woman is older, they may feel the urgency of her limited reproductive capacity. The plan to have a baby at a certain time of year is often replaced by the desire for a baby anytime and soon. The couple may feel uneasy with child-related activities because they are uncertain when or if they will be parents. They may feel hurt when other family members or friends have babies. Events focusing on infants or small children may become melancholy rather than joyful occasions. Family members and friends who are having children may feel guilty when they are around the couple who cannot conceive. The potential grandparents may think their children are waiting too long to start a family, or even that they are selfish. If they are aware the couple is trying to conceive, they become even more worried as the months pass without the longed for announcement of a pregnancy. They are twice saddened by the lack of a grandchild and the hurt their adult children are enduring. Seeking help for infertility. Eventually, couples must decide whether to seek help to conceive. They may reach this point after only a few menstrual cycles or, at the opposite extreme, may never seek help. Many factors enter into the decision, such as their ages, especially in older women, how long they have been unable to conceive, how much they desire a biological child, how they regard adoption, and how they feel about a life without children. If they have a biological child but are unable to conceive another, the couple may consider adoption sooner. Identifying the importance of having a baby. Each partner may place a different priority on having a baby. Conflicts may arise when one partner wants help to conceive sooner than the other. In addition, cultural or religious beliefs influence the way each feels about procreation and whether options such as assisted reproductive procedures or adoption are acceptable. The way in which the couple resolve these differences is crucial to the stability of the relationship. Men and women often differ in their reactions to infertility, although they are equally affected. Women may want to talk about their feelings and frustrations, but men often internalize their feelings or think they must be strong for their partners. The woman may interpret her partner's stoicism and reluctance to express his feelings as disinterest or lack of concern and care for her. Sharing intimate information. Evaluation and treatment for infertility require that both partners reveal information about their sexual relationship, such as the frequency and timing of intercourse. This may be difficult for those who regard this information as intimate. In addition, infertility couples may think the evaluation calls their sexual adequacy into question. They may feel defensive if they perceive a threat to their self image. Considering financial resources. Financial concerns enter into the couple's decision about whether to seek treatment and how far to carry it. Techniques such as ovulation predictor kits are inexpensive but have limited usefulness in achieving successful pregnancy. Advanced techniques such as IVF are expensive and may have a low likelihood of success for some couples. Health insurance may or may not cover infertility treatment or may cover only certain procedures or medications. Investigational treatments are usually not covered. The drugs that must be taken to achieve pregnancy are often quite expensive. Expense and restricted coverage limit treatment choices for many couples. Those who seek and pursue infertility treatment may have greater financial resources than those who do not seek treatment. Committing to involvement in care. Infertility evaluation and treatment require a great commitment from the couple in terms of time, emotional and physical energy, and money. Couples can be involved in this process for several years if they do not set a limit on when they want to stop. They participate daily as they do home assessments, take medications, and keep detailed records similar to what they might do in their jobs. The physical effects of drugs that induce ovulation and support conception can result in many side or adverse effects. For infertility diagnosis and therapy to be most effective, couples should consider their ability and desire to be directly involved in the process over what may be a long time. Reactions during evaluation and treatment. Couples undergoing infertility evaluation and treatment have different reactions to the process. Although early evaluations often result in simple treatment and quick response, a couple's reactions may change as treatment becomes more complex, demanding, and lengthy. Influences on decision making. If their evaluation shows that a treatment or procedure may enable them to conceive, the couple may then decide whether to proceed. The decision-making process begins early and must be repeated during therapy if pregnancy does not occur. A complex array of factors enters into their decisions about beginning and continuing treatment or whether to end their pursuit of pregnancy. Although discussed separately, these factors interact dynamically as the couple makes each decision. The nurse helps them examine each factor and arrive at a decision that is best for them. Social, cultural, and religious values. Some medically appropriate options are not acceptable to every couple within their personal, social, cultural, and religious frameworks. Surrogate parenting, IVF, and therapeutic insemination, especially with donor sperm or egg, are not consistent with the personal or religious beliefs of some people. Procedure offers the partners hope for a child but is incompatible with their beliefs. Their choices are to use the technology despite their beliefs or be willing to accept childlessness. Adoption may be a third alternative for some couples if the desire for a biologic child is not absolute. Adoption of a foreign child may be necessary, with associated international implications. As in other decisions, couples must work out conflicting personal values about what therapy is acceptable. Difficulty of treatment. Couple must consider how difficult, risky, and physically and/or emotionally uncomfortable therapy may be. The level of difficulty involves physical, psychological, geographic, and time factors. Employment constraints also may affect treatment decisions. Several diagnostic tests and treatments for infertility involve invasive procedures or surgery. The person who undergoes a procedure should be the one who ultimately decides whether to do it. That person alone, with input from his or her partner, can decide whether the hope for a child is worth the risks and discomfort of the procedure. Infertility treatment is stressful. Often partners feel or are willing to tolerate different levels of stress. To reduce the stress, they may abandon treatment completely or take a break for a few months from the constant preoccupation with conceiving. Women nearing or in their 40s often do not feel they have the luxury of skipping a treatment cycle. Some couples encounter geographic difficulties if they must travel a long distance for therapy. Time stresses are substantial, and one or both partners may spend many hours every week in pursuit of pregnancy. Employment constraints may be a barrier to infertility therapy because of the time required for treatment. Probability of success. Couples often have a biased interpretation of their statistical probability of success, especially when they begin treatment with a new procedure. For example, if a procedure has a 20% likelihood of success with each cycle, they tend to expect they will be in the successful group rather than in the 80% who do not meet with success. As time goes by, however, they must weigh the likelihood of success of any therapy against financial concerns and their own willingness to accept the discomfort and difficulty associated with it. Again, the woman's age imposes an inescapable limit. Financial concerns. Some couples, particularly those with ample resources and a strong desire for a biologic child, pursue expensive treatments and do so longer than others of more limited means, despite a low probability of success. Couples with financial limitations find they must abandon treatment sooner than they want. Other couples go heavily into debt, adding financial strain to the other stresses of treatment in their quest for a biologic child. Psychological reactions. Couples' initial reaction to infertility often is one of shock and sadness because the partners are usually healthy and did not expect to have problems conceiving. The reactions vary according to how easily their infertility is alleviated, their personality and self-image, and the strength of their relationship. Guilt. Partner having the only identified problem might feel that he or she is depriving the other of children. This feeling may be compounded if the normal partner has children from another relationship. It may be difficult for the person to understand that not all factors affecting infertility are known, and what seems like a problem of only one partner is often the couple's problem. Either partner may feel guilty about past choices that now affect fertility. A woman with adhesions resulting from a sexually transmitted infection may regret her past sexual choices. The man who wanted to delay pregnancy longer than the woman may feel guilty if her age is now reducing her fertility. Isolation. Infertile couples may withdraw from friends and relatives who have children to insulate themselves from painful reminders of their infertility. Some couples develop supportive relationships with others who are infertile, which somewhat diminishes the sense of isolation. Depression. One or both partners may experience depression as their sense of competence and control over their bodies is challenged, especially if therapy is not successful quickly. They often feel as though they are on a roller coaster of hope, alternating with despair when the woman has her menstrual period each month. The couple may feel envy toward those who conceive easily. Stress on the relationship. Because infertility can challenge a person's identity and self-esteem, partners may find less satisfaction in their relationship. The man may have difficulty ejaculating on demand for semen specimens or post-coital tests, feeling that others will judge his sexual function. The fact that semen samples are best obtained by masturbation in office setting is unacceptable or uncomfortable to some men. Both partners may be stressed when intercourse must be scheduled to coincide with specific evaluations or ovulation. Intercourse can become a chore more than an expression of love. It may come to be associated with failure rather than fulfillment if a pregnancy is not forthcoming. Sperm from an anonymous donor is used for therapeutic insemination or other techniques. The man may feel that his masculinity is further threatened. He does not want to deprive his wife of a child, but he may be ambivalent about use of sperm from a third party. He may have difficulty distinguishing between fatherhood as a biologic achievement and fatherhood as a relationship. The couple may find the relationship strained if they disagree on which treatments are appropriate and how long they should be pursued. One partner may want to keep trying one more month, and the other may want to abandon treatment. If they are considering adoption, the relationship again may be strained if they differ on whether to adopt and what kind of child they are willing to adopt. Outcomes after infertility therapy. After infertility therapy, three outcomes are possible. A pregnancy may occur and continue to a live birth, may end in pregnancy loss, or may not occur. If pregnancy loss occurs, or if infertility therapy is unsuccessful, the couple must decide whether to pursue adoption or to remain childless. Pregnancy loss after infertility therapy. Couples who suffer pregnancy loss after infertility therapy may interpret the experience with mixed feelings of loss and gain. Couples undergoing infertility evaluation and treatment often are aware of a pregnancy much earlier than fertile couples. They want to hope yet expect to be disappointed again. If spontaneous abortion occurs, they may grieve profoundly for what they achieved and then lost. Yet despite their grief about the pregnancy loss, partners may be encouraged because they have achieved a pregnancy. They may feel that if they succeeded once, they can become pregnant again. A miscarriage may give them the courage to continue or restart treatment. If a pregnancy results in an ectopic pregnancy, the woman may lose a fallopian tube, although earlier diagnosis reduces the risk for damage or loss of the affected tube. These couples may have an added threat to their fertility because of the increased risk for ectopic pregnancy and future conceptions. Parenthood after infertility therapy. Couples who conceive experience varied emotions. If they have been disappointed before, they may be hesitant to be optimistic about this pregnancy. They will be happy but still anxious about whether they can complete the pregnancy and realize the dream of taking home a baby. Pregnancy after infertility therapy is emotionally tentative for many infertile couples, especially those who have been trying to conceive for a long time or have lost a pregnancy. They may distance themselves from the reality of the pregnancy until much later in gestation than normally fertile couples. The woman has learned to sense and report every symptom and may interpret normal changes of pregnancy as a threat. Preterm labor may stir greater anxiety in the previously infertile couple. The woman may assume that intermittent periods of fetal quiet are abnormal rather than naps that are normal for every fetus. The previously infertile couple may find little support from those who do not understand their fear of investing in the pregnancy. Other infertile couples who have been a source of mutual support may either withdraw from the couple who achieve a pregnancy or rejoice in their success. The parent's anxiety may be heightened during labor. They may be afraid that something will go wrong at the last moment. Even after the birth of a healthy infant, some parents need time to relax and grasp the fact their baby is really alive and well. Choosing adoption. Not every couple who seeks treatment for infertility achieves a biologic pregnancy. Some couples discontinue treatment sooner than others, depending on their age and tolerance for the fatigue, stress, and expense. Some couples investigate adoption early in infertility treatment if a non-biologic child is acceptable to them. A single parent may choose adoption. Agencies that coordinate international adoptions are often consulted. Couples who consider adoption must confront their personal preferences, limitations, and prejudices. As much as they want a child, many couples are not willing to adopt a child with special needs, one of a mixed or different race, or a group of siblings. Some couples fear adopting a child because the woman might then spontaneously become pregnant. Although pregnancy has been their goal for a long time, they may worry that they would love their adopted child differently from their biologic child. If the couple plans to continue trying for a biologic child, they also must come to grips with this issue. Couples who decide to adopt face further scrutiny of their personal lives. Agencies investigate their home, financial means, which may have been seriously drained, and fitness as parents. Once again, they may feel their personal competence is questioned. International adoptions often have many additional requirements that the couple does not encounter in their home country. The couple who decides on adoption may have emotions similar to those who achieve a pregnancy. They may be slow to invest in the process emotionally because they expect disappointment again. In addition, the adopted child often arrives suddenly and unexpectedly. A delay in their adoption process may occur. bringing further uncertainty to the couple. Although they may have been waiting months for this happy event, the couple may have little time to adjust to the reality of their new roles as parents. Menopause after infertility. A woman or couple may decide when to stop unsuccessful infertility treatment, or natural biologic aging may make that decision for her after many attempts to conceive and carry a child to term. Her ovarian reserve may be exhausted and she may become perimenopausal or menopausal. Application of the nursing process. Care of the infertile couple. Nurses may encounter couples facing infertility in many different settings and identify numerous nursing care needs. Regardless of the setting, the nurse often addresses the couple's emotional needs associated with infertility evaluation, treatment, and outcomes of therapy. Assessment. In many instances, infertile couples previously had a positive self-image and feelings of competence about themselves. The diagnosis of infertility may alter this positive view. The nurse should be aware that these feelings may be present regardless of the practice setting in which the couple is encountered. The nurse should determine at which point the couple is in their infertility treatment journey. Couples who have just discovered they may have difficulty conceiving may be shocked, yet optimistic, that therapy will result in a baby. Other couples for whom simple treatments were unsuccessful may face shock again if the more complex treatments such as IVF or ICSI are recommended, particularly if these treatments may result in financial hardship. Listen for remarks that are negative, expressing guilt or helplessness. Evaluate the way infertility has affected the partner's relationship with each other. Are there conflicts or differences in values between the two? Observing their body language, such as eye contact, may provide clues about similarities and differences in their commitment to diagnosis and treatment. Ask them how their relationship has changed. Are they more or less satisfied with their marital relationship than they were before they had problems conceiving? How is each member of the couple adjusting to the situation? Ask about support systems. Couples suffering from infertility often withdraw from old relationships, yet do not form new supportive ones. Do others who are significant in their partner's lives know that they are trying to conceive? Are family members and friends nearby, and are they supportive? Have they sought the counsel of a therapist trained in infertility? Ask whether they have encountered assumptions by others that infertility is the fault of one partner or the other. Are they subjected to questions that invade their privacy, such as, when are you two going to have a baby? Determine how the couple's culture or religion views infertility and the impact of these values on therapy. Are some therapies unacceptable to one or both partners? The partners may have differing views that can cause conflict during treatment, and they may need help to work these out. Determine how the couple is coping with the stresses of treatment. How much has infertility cost them in terms of time, money, and discomfort? Identify the successes and failures they have experienced, as well as outcomes that have provided them hope or comfort. Their ages, especially the woman's, add another stressor that cannot be ignored in their decisions. If the woman is pregnant or has given birth recently, or the couple has adopted a child recently, observe for high levels of anxiety in either or both parents. Assess them for negative behaviors and comments, such as reluctance to feel joy or a sense that they will fail again. Identification of patient problems. Infertility can result in a patient feeling anxious, hopeless, and a sense of loss. An appropriate patient problem is altered self-confidence resulting from a loss of control. Planning expected outcomes. 3 expected outcomes are appropriate for this patient problem during the early days of evaluation and decision making. The outcomes may apply to the man, the woman, or both partners. The person will do the following. Express feelings about infertility and its evaluation and treatment. Explore ways to increase control within the situation of infertility. Identify aspects of self that are positive. Interventions. Assist communication. Therapeutic communication is the primary technique for assessment and intervention related to this patient problem. Recognize that either partner may be reluctant to express his or her feelings as openly as his or her partner. A variety of communication techniques, such as active listening and exploration, may encourage the partners to express their feelings honestly. Provide privacy and acceptance of their feelings. Nurses should recognize the validity of the couple's views and emotions, even if they differ from the nurse's own feelings. Encourage the partners to accept their feelings, both positive and negative. The partners may act elated because they believe they should feel happy, yet inside they are cautious and hesitant about becoming attached to their baby. Explain that feelings are not right or wrong, but simply exist. Opening the subject of negative feelings, fear of attachment, within a successful situation, pregnancy or birth, may be helpful to reinforce the normality of their emotions. This technique gives them the opportunity to talk about emotional reactions that they or others feel are inappropriate and might otherwise be reluctant to discuss. Discuss possible differences in ways the man and the woman communicate. For example, explain that the woman may feel more comfortable than the man in talking about their problem and concerns about treatment. Explain that these differences in communication style can cause misunderstandings because one partner believes that the other does not care as much about their problem. Encourage them to be open with each other for the best mutual support. Support groups provide another means for communication and ventilation of feelings among those who are most likely to understand what an infertile couple is experiencing. Increase the couple's sense of control. Explore how the couple has dealt with stressors in the past and how these techniques might be used to cope with the present crisis. A couple's pattern of dealing with stress in other parts of life is likely to carry over into infertility diagnosis and treatment and throughout pregnancy and parenthood. Reinforce positive coping skills such as learning more about infertility and the proposed therapy for it. Couples who experience undue stress may benefit from relaxation techniques such as visualization and moderate exercise. Frequent strenuous exercise may reduce the woman's ability to ovulate. Although a hot tub is relaxing for many people, it should be avoided because the high temperatures may inhibit spermatogenesis. In addition, the woman could become pregnant with any cycle, and high maternal body temperatures may be associated with fetal anomalies. Discuss behaviors that enhance the ability to handle stress and provide a good environment for a pregnancy that might occur. Reinforce healthy choices such as good nutrition and a balance between exercise and rest. Teach the couple ways to enhance general health if deficiencies are identified. Explain any procedures and their purpose in language the couple can understand. Reinforce any medical explanations that may have been given. Encourage questions so that the couple is fully informed. Have the partners restate what was explained to reduce misunderstandings. Help the couple explore options at each decision point. The couple must decide the best course of action, but the nurse can help identify pros and cons of each choice so the partners can arrive at a decision appropriate for them. Be non-directive so the choices are theirs and do not reflect the biases of the nurse or other caregivers. Reduce isolation. Because couples often distance themselves from friends and family relationships that they find painful, they may have little social support. Refer them to available support groups to provide emotional outlets, a sense of belonging, and a source of information. Couples who achieve pregnancy or adopt a child may again find themselves isolated if infertile couples in their circle of support are no longer comfortable with them. Encourage them to take the initiative to reestablish ties with relatives and friends, who can be an important source of aid during pregnancy and childbearing. Help them identify ways they can improve communication with these significant others. Remind them that they have undergone significant shifts in self-image, which also have affected those around them. Promote a positive self-image. Because infertility work often is such a dominant factor in their lives, a continuing inability to conceive erodes the partner's perception of themselves. Explore with them other areas of competence and activities that make them feel good about themselves. Reinforce positive attitudes and self-evaluations. Encourage them to maintain activities such as hobbies, sports, or volunteer work. The career of either partner may be a source of stress that needs relief, or it may be an avenue that fosters a positive self-perception. Encourage them to avoid activities that involve infants or children if these events make them sad. Help them identify the best ways to cope with these activities if they do not want to avoid them. Some people benefit from self-improvement activities such as continuing education courses or enhancement of appearance. Encourage these activities if they help the individual feel better about themselves. If the activity might impair fertility treatments such as strict dieting, also inform the person of this fact. Evaluation. The goals established are achieved if the individual or both partners can do the following: express their feelings about their situation, usually over time. Explore ways to increase personal control over their lives, as evidenced by expressing feelings of reduced helplessness and dependence. Identify one or more aspects of self that are perceived as positive and identify areas of competence.